All right, perfect. Just wanted to go through this. Over the next, hopefully less than 10 minutes, we're going to do a few things. I'm going to give you some updates on the latest publications from the clinical trials, and we're going to really go into those in depth and go through all the nuances of those studies. I also want to talk about a couple of the problems and controversies that are there with discs, and I think a lot like myelopathy, we're going to find that we really don't have any research other than our clinical trials. That's very good. Talking a little bit about levels, same kind of thing with whether it's one or two and what we do. And a little bit about some of the future directions that we have. So kind of just to start off, this was kind of a study done where they kind of interviewed 383 AO Spine International members just to look at what they did with arthroplasty. And what we found is that only about 50% of people actually even used arthroplasty to treat radiculopathy. And only under 10% used it as a standard for treating radiculopathy. So what were the questions they had? One was the lack of evidence. And this was really not that old of a study, but the other concern was cost. And so with that, this is kind of what we look like right now. There's a lot of discs on the market right now with various things and really a lot of evidence and trials to shift through and really trying to break that down in what we're doing. So starting with ProDisc, this was introduced in 2002, and what did they really find? They looked at the 7-year data from this. And to highlight a few of them, everything was a little bit different, but the most important things that really came out of this paper was reoperation rates of only 7% for the ADR group and about 18% for the ACDF group. The other thing we're going to talk about a little bit later is this HO, the heterotopic ossification. They had about 11% that involved loss of motion in that study at 7 years. Moving on to Moby C, because a lot of people are familiar with this. This is probably the most popular disc in the States right now. When they looked at overall success, and just a quick note on that is that when they look at success, there's lots of different things with the FDA criteria. So I think the more important thing about this was the comparison to ACDF. One level, they were about the same for their overall success, but that at the 2 level, there's pretty significant difference with overall success in about 60% versus about 35% for the ACDF. Again, they found about 11% of bridging bone in both the 1 and 2 level discs. But they both maintained motion. They both decreased adjacent segment disease in both the 1 and 2 levels. And there was a reduction in secondary surgeries. And again, this was done as a non-inferiority study, but the 2-level group did show superiority to ACDF. So the Bryan disc, again, not a lot. Overall success rates were pretty good. They looked at it maintained angular motion, decreased adjacent segment disease. Those are the big findings. But this is at least 10-year outcomes. The big problem was really follow-up. It was about predicted for what they thought at 10 years, but really only about 55%, 54% of people showed back up for the ADR and 48% for the ACDF. So this is the Prestige LP. Again, 10-year data that came out. Reduction in secondary surgeries with about 9% in their ADR group and 17.9% in their ACDF group. The 2-level, though, with grade 3 or 4 HO really showed about 39% in that study. And then when we looked at the single level, they didn't really find any changes in terms of their overall status from the 7-year data, but they did find a significant kind of increase in HO over the years, from 2 years to 7 years to about 9% at the 10 years. At the 10-year mark. So another one on the market right now is Secure C. Interestingly about this one, they found about 7% HO, 7.7% of heterotopic ossification. The most interesting thing I found in this study is when they published the 7-year data, I know that the Globus guys were always marketing that they had clinical superiority for a single level in their study, and that kind of disappeared at that 7-year mark. So there is some question about what's going on with that one. Then the M6, people have heard about this. This disc came out probably within the past year. We're still waiting on the 2-year data publication. It's supposed to be out soon. But they did kind of compare flexion extension between the M6 and the Moby C, which did show kind of relatively the same amount of motion, inflection and extension. But the reality with this disc is to stay tuned. We just don't know enough about it yet. So what is it? If we kind of compare and do a literature review of all these, amazingly, they kind of looked at all these studies, and what do they find? Well, the discs aren't the same. That we really need to look at it. They have different rates of adjacent segment disease, HO, and reoperation rates, and some of that's going to be how the studies were designed, but it's true. The discs aren't all the same, right? Different axes of rotation. They have different levels of constraint. There's different sizes and shapes and all these things that we have to think about when we put them in. So my advice to you is, it's not just about one disc is the right thing for every person, but to really think about these discs and the people that you're putting them in, and things can vary on that. So what is the HO, and what did this really show us? Well, the reality is it happens. We know it. We see it in the clinical trials, but the question is, what is its clinical significance? And the only thing we can tell you is we need to do more research on that, because it really didn't change the overall success rates of most of the studies. And the studies kind of were based differently, whether they reported the degree of heterotopic ossification. So a little bit on that. The surgery center question, again, a little more research needs to be done on this, but there was a comparison done. About 145 patients they treated in an ASC. They found shorter surgery times, less blood loss in the ASC. I can't really understand why they would have found that. And they predicted that kind of 1 and 2 level surgeries were fine to perform in an ASC. My advice, I still keep all my patients overnight and put a drain in. So if you've got an ambulatory surgery center that you can do that, I think it might be safe. But again, I don't know that this is something just from 1 or 2 articles that I would jump into. So talking about levels, what are the long-term results? Really shown they can have equivalent outcomes. Most of those studies were all non-inferiority studies, so they really weren't going to be able to show us a whole lot. Potentially, they do have a lower cost in terms of revision rates and things like that. But again, as everything else that we've done, when we looked at things, we found out that really the biggest deal is that the 2-level has more HO, but no one's really sure what that means, again, and that we still need to do a lot more research on this. I think our best research is really coming from the RCTs, and we really haven't done a whole lot outside of that. So my advice to you all, if you're going to do multiple levels, is just to know which device you're using. Remember, they have all got different aspects to them, and just make sure that you know how to balance them well, because that's probably one of the biggest problems with multi-level TDRs. And just definitely, if it's your first time using one of the devices, don't make a multi-level your first case. So where are we going to go in the future? And I guess some of the things are going to be hybrids, whether this is done as an initial surgery or whether it's going to be adjacent to a prior fusion. Again, the literature is kind of not there yet. We don't know. I just say that it's if you believe in the tenets of arthroplasty, and I'm not sure that everybody does, but I do. I think it's certainly a reasonable option. The other thing that I think you're seeing, we're finding, is that with the newer disc, the M6 and the Simplify, which will probably be coming out a little bit later this year, is people are moving away from kind of that typical metal on poly. The metal on metal disc was pulled. I think there is a concern for wear in the future. We are really only looking at 7 or 10 year data, but I think a little bit later on we may find some problems with that. But again, we'll still have to wait to find out. So this is kind of, at least with the number crunchers thing, right? In that 2017, there's about 541 million was the total disc market. Most of that was cervical, and that we're kind of increasing, and they expect, over the next few years, this to kind of take off. And so, can I end this, as I think I'm going to be able to finish within the 10 minutes, is I really want you, if you take nothing else away from this entire talk, is the next slide, which is probably, the most important article that's come out, one that's blown me away in the past year, because it was published in the most prestigious Food and Beverage Herald. And they looked at cervical total disc replacement, and what did they find? To my surprise, it's MIS, which really impressed me, with a quicker recovery, shorter hospital stays, lower revision rates, and the fact that industry's acquisitions and mergers have spurred the trends. Interestingly, opposed to the AO, doctors apparently prefer disc replacement over fusion. And I think they also mentioned that cervical arthroplasty goes well with beer.